Okay, thank you very much for inviting me, and I'm very happy to share with you this talk about infertility and PCD. So as you mentioned, I'm more reproductive endocrinology than a PCD specialist, but there are PCD specialists on the board. So I thought that if we want to talk about infertility and PCD, it's important to have data about fertility in the general population. So I'm going to mention what is known right now about fertility in the general population and what are the main causes of infertility in the general population and how we can manage those causes of infertility. And then we will go to the work of Leonie, and we can share some data. So first of all, a very important notion is that total fertility rate has decreased between 1960 until up to 2020 worldwide. The yellow curve is the number of so is the total fertility rate per woman. So you can see that it was around 5, and now it's worldwide above 2. Now, if we focus on Japan, for instance, you can see that the total fertility rate is much lower. It's even below 2, which is the normal amount of children for the renewal of the population. So there's a major issue is that fertility is decreasing worldwide. It may be due to the fact that women are using more and more contraception, but it also may be due to the fact that infertility is rising. So what is the real definition of infertility? It's an inability of a couple to conceive after 12 months of regular intercourse without using any contraception in women when they are less than 35 years of age. And it might be after 6 months of regular intercourse without the use of contraception in women 35 years of older. This means that women that are more than 35 years old need to be taken care of after 6 months of infertility. So this is the exact definition of infertility. And an important issue is that in the general population, 1 out of 7 couples are going to consult for infertility. So it's very frequent to have infertility in the general population. So what are the main causes? So this is quite an old study, but it's very important to have the basis of the causes of infertility. So in the general population, it's mainly anovulation related to a syndrome called polycystic ovarian syndrome. So it's very important because when we mention infertility in PCD, this woman with PCD, she might also have polycystic ovarian syndrome, which is very frequent. In the general population, it's about 10 to 15% of women. And you can see it represents 32% of the causes of primary infertility, meaning never have any children or never started a pregnancy. Tubal infertility was 26%. So this is globally the female causes of infertility. And then looking at the male causes of infertility, it can be a low number of sperm, a lack of sperm motility, and that's very important for probably men with PCD, or abnormal sperm, or no sperm, or azoospermia. And what's important is that in 35% of cases, there's a mixed etiologies, men and women at the same time. Therefore, when we evaluate the fertility of a patient, you need to have data on the male or the female partner, which is not very easy on a regular basis. And other important data is that the optimal fertility is between 18 to 32 years old. And in every woman, there's a decline on fertility, and globally the end of fertility, spontaneous fertility, is around 42 years old. So this is due to the fact that the number of ovarian follicles decreases with age. So the decrease starts even during intrauterine life, but then this decrease goes during the life of the woman, and menopause occurs when there are less than 1,000 follicles in the ovary. And this is very important because a lot of women are actually delaying the first child. And if you delay the first child, the risk of being in this section, the declining fertility section, is higher. So as the number of follicle decreases, there's a proportion of poor quality oocytes, and therefore of pregnancy loss that is increasing with age. So since the data I showed you in 1990, in the 90s, nowadays there's more and more increasing causes of what is called diminished ovarian reserve. So those women, they have nowadays less tubal origins because there are less infectious disease, but they have increased rate of diminished ovarian reserve. And this is due probably to delay in pregnancy intention. The first child is usually at the age of 31, and it was before 25 or 26. It might be to genetic causes or also to endocrine disruptors. So this is very important to have data on the ovarian reserve of the woman wishing a pregnancy. Furthermore, there's more and more data about endometriosis, and endometriosis is the fact that the endometrium might go into the abdominal cavity, and you can see here a huge increase on bibliometric analysis research on endometriosis, and it is nowadays known that endometriosis by itself reduces the number of follicles. Therefore, it is an increasing cause of infertility. Now, if we look at the male data, here you have in this publication from 2000, 101 studies showing that there is a sperm density, the sperm density is decreasing and has decreased since 1930 to 1990. And now we have, there's a big study performed in France in more than 26,000 men, and they were evaluated because they were sperm donors. So they had given sperm in the 90s, early 90s, and then further later on. And what has been shown is that a decrease in sperm concentration, 1.9% per year, between 1989 to 2005, a total decline of 32%. And this is really worldwide because you can see here in this figure extracted from a very interesting paper published last year in Nature Reviews Endocrinology, looking at all causes of infertility, that you can see here, if we look at unselected Western sperm concentration, between 1970 and 2010, you can see a 52% decline. So there's really a major issue about the declining number of sperm concentration. And one of the hypotheses is based on environmental factors that could have an impact on sperm count and maybe sperm motility. So this is why the World Health Organization, the WHO, has modified the number of sperm that is the lower reference value. Now it's considered normal, the lower end of sperm concentration, 16 times 10 6. And the total mortality is 42%, and the normal forms 4%. So before it was considered normal between higher than 35 million. And you see now that number is much lower, considered normal, 16 million. So this is very important when we want to interpret data about patients having infertility and looking at sperm data to see if they have or not infertility. In quite a large number of patients, actually, it's unexplained infertility. It means that no cause can be identified after a female and male checkup. So female checkup includes hormone levels, measuring FSH, estradiol, testosterone, AMH, or anti-Müllerian hormone. It's the best hormone to be related to the follicle number. A pelvic ultrasound is also able to see the follicle, antral follicle count, and hysterography is necessary to evaluate tubal permeability. And in men, sperm count is the best exam to evaluate the number, the motility, and the shape of the different sperm. But unexplained infertility is still 15 to 30% of infertile couples. Therefore, a lot of people are actually need to have medically assisted reproduction, or MAR. And medically assisted reproduction depends on the type of infertility. So when it's a male sperm number, what can be done is intrauterine insemination, meaning that with a catheter, the sperm is injected directly in the uterus, and therefore it increases the number of sperm that is already in the uterus and therefore can meet the oocyte in the tube. A second procedure, of course, is in vitro fertilization, and this needs stimulation of the ovaries, and then egg retrieval from the ovaries, then fertilization of the eggs, embryo maturation, and the last step is transfer of embryo to the uterus. So this is for mainly anovulation and also for tubal causes of infertility, and even in diminished ovarian reserve, people are doing some IVF. Of course, in some cases of anovulation, what can be done is a single stimulation, ovarian stimulation, without IVF. Just the woman has injections of FSH, and then she can be, it replaces the follicle recruitment, ovulation, and then she can be pregnant with without IVF. And within the techniques of IVF, so here you have IVF with the sperm that are placed along with eggs and leave them to the natural process of fertilization. There's another technique called ICSI. ICSI is for intracytoplasmic sperm injection. And this ICSI is the fact that a single spermatozoa is injected directly into an egg to achieve fertilization. This technique is used when the number of sperm is very, very low and when the motility is altered so that the fertilization is enhanced. So this is exactly the intracytoplasmic sperm injection, where you see the injection under the microscope of a sperm within the oocyte. So, of course, in PCD, one can probably make the hypothesis that the sperm is not going to move correctly due to all the genetic defects that are present in the sperm. One can also make the hypothesis that if the motility is not correct, then there's the sperm is not going to migrate normally. And in the women, of course, one can assume that probably in the fallopian tubes, the ciliary motility could be altered due to the fact that this genetic defect in the lung can also be present within the fallopian tubes. The major difficulty is that so far nowadays, there's no way to evaluate the motility within the fallopian tubes. You can see whether a liquid can go through the tubes and whether the tubes are not obstructed, but right now you need this electron microscopy would need to have a sample of a tube, and right now this is not feasible on a routine base. So this is what I wanted to present as an introduction, showing that infertility in the general population is quite frequent, and the main causes can be female or male causes, and in most cases, mixed causes. So if you agree, maybe Leonie now can present her questionnaire and the data concerning the questionnaire. If Leonie, you're okay with this?
Sounds perfect. Thank you. So now I can also try to share my screen. I hopefully that I'm able now that I open up this Zoom. Can you see the correct screen?
Yes.
Great. Thank you very much. I'm also very happy that I can be here and tell you everything that we know now with the study we conducted about fertility and PCD. So thanks to the introduction of Sophie, now you know already the very important basics also about the mechanisms that can lead to infertility in PCD. Now, of course, when we then have maybe a patient that talks to us, they will probably not ask, and what about my motile cilia in my fallopian tubes? But they will probably ask questions such as, will I be able to conceive a child? And a female with PCD may ask, am I at higher risk of having an ectopic pregnancy? And to date, we actually know very little about these two questions. And why do we know so little? The problem is a bit in PCD that there are many different problems that are more studied. So here I have listed some explanations why we know so little about fertility and PCD. And for example, now it works. So for example, fertility is not regularly recorded in medical charts. It's not something that when someone enters the practice that you just, the first thing you ask is, how is your fertility? And then write it down. It's also a complex issue. I think Sophie described that very nicely. It's not just that you can do then one test and you know if someone is fertile or not. It's really difficult to assess, and you also have to take into account the partner's fertility. There is also really limited awareness still among physicians, and also very little knowledge on the topic. It's not a life-threatening symptom of PCD, and mainly people are concerned when they try to start a family. So now I'd like to briefly summarize the current evidence we have more on the prevalence of infertility and ectopic pregnancies in PCD. So I will start with a systematic review and meta-analysis that was done by Gutaki et al. And published in 2016. And they could include 7 studies that reported infertility in PCD. And here on this forest plot, you can actually see, also when you're not an expert in meta-analysis, that they actually found quite a huge range between 15% to 79% of infertility in PCD. And they managed to calculate a weighted mean of around 30%. And then they could also look at 4 studies that stratified by sex, and they could show that there around 58% of females with PCD were infertile and 100% of males. 1 year later, a study was published by Vanneken et al. That included 85 adults from France and Belgium. It is a cross-sectional study, and they use really clinical data. Either they got it from the chart, or a physician assessed the fertility status. And there they could include 36 females with PCD diagnosis. And among those 36 females, 22 were infertile, which is 61%. And out of these 22 infertile females, actually 6 became pregnant with assisted reproductive technology, so short ART. But here we don't really know if the other 16 females also tried ART, so we cannot really talk about the success rate of ART. They also reported a miscarriage rate of 8%, but they didn't show any ectopic pregnancies in this population. And maybe this is something to mention again, that even though we think that these motile cilia somehow affect the oocyte moving to the uterus, until now we don't really have evidence that females with PCD have more ectopic pregnancies, so pregnancies outside the uterus. Here they couldn't show any. Now among males, they could show that 37 of 49 males were infertile, which is 3/4, and again here 15 benefited from ART. And of course, in PCD, we're also always very interested if the fertility status, or if any symptom is also associated with the genotype. And they also looked at this. And again, it's always quite small numbers, but I think it's really interesting that they could show that some groups, actually some defects, were more likely to be infertile. So if we look at, for example, quite in the middle, in the upper box, CCDC 39 and CCDC 40. Again, on the left side, the males, that actually almost all males that reported one of these that had one of these genes affected were infertile. Then this year, actually, there was a narrative review published that included 108 publications and wanted to also assess fertility prevalence and look very much into detail about everything we have on this topic. And they as I just showed you, actually could only mostly include case reports and case series, because the study I showed you by Vanaken et al. Is actually the largest study to date. And they could show that in all these studies, they included that among females, up to 61% were infertile. And that's actually just the number that was also assessed by Vanaken et al. That's that's the number from this publication. But then they also looked at pregnancies after ART. And here they could show that actually among 20 females in case report that tried ART, 17 had a successful pregnancy. But here, of course, we need to be very careful, because they were just reported in case reports. So there we probably have a problem of publication bias, that more the successful cases were reported and not the unsuccessful ones. And in all the publications they found 4 women who had a spontaneous ectopic pregnancy. Then among males, they could show that up to 83% were infertile, and this number is based on a study from Monroe et al. In 1994. And if we look a bit closer, actually there were only 12 males included, and 2 out of these 12 fathered a child. But here they don't have information if the rest also tried to father a child. So probably these 83% were maybe a bit the overestimation of infertility. And also here they could show that 54 of 65 males in case report had a pregnancy after ART. So we cannot say much about the success rate of ART, but we can still say that it works in certain cases. Now, to summarize what we know so far, I think we can say that unfortunately the quality of evidence is quite low. We really have only one larger study with 85 participants, and we know more about male infertility than female infertility. We could also see that fertility treatments are likely beneficial, but we really have little data on its use and efficacy. And we only really have anecdotal evidence on ectopic pregnancies. Now, what did we do to know a bit more about that topic? As Yinting already mentioned in the beginning, we wanted to study infertility and ectopic pregnancies using data from the Living with PCD study that was formerly called COVID-PCD. And I think this study, quite some of you know, because it was also already a part of an earlier session and an earlier expert talk. For the ones that don't know the study, the COVID-PCD study is a study that was set up more than 3 years ago at the University of Bern, together with patient support groups around the world, to study COVID-19 influence on people with PCD, but also to study other topics that are important for people with PCD. It is an international participatory cohort study, and it is based on online questionnaires that can be completed anonymously. And participants can easily self-register on our study website, and everybody actually with suspected or confirmed PCD from all over the world can participate. And the questionnaires are available in English, German, Italian, French, and Spanish. And up until now, we have already 759 people from 49 countries included. Now, what did we do? As I said, it's a questionnaire-based study. So we send all our participants a questionnaire on fertility. And as you can see here on this slide, we also, when they register to the study, first they receive a baseline questionnaire, and then we send them a fertility questionnaire. And in this fertility questionnaire, we asked, for example, have you ever tried to become pregnant or father a child? And if they replied yes to this question, we ask more about how did you do it? Did you use fertility treatments? Yes or no? What was the outcome of that pregnancy? And we also assessed many other factors that can influence fertility. Now, for the analysis on infertility and ectopic pregnancies, we could include 265 adults, of which 68% were female, and they had a median age of 44 years. and that you can follow me on the following slide. I use a slightly different definition for fertility and infertility than Sophie used before. So fertility we defined as spontaneous pregnancy, and infertility as the failure to establish a pregnancy within 1 year, or as the use of fertility treatment. So we could include 118 females and 50 males who had already tried to achieve a pregnancy. And among the females, 39% were fertile, and among the males, 22%. So actually quite a big proportion of our participants were infertile. Here you can see on the left side, 61% of females, 78% of males. But as I mentioned, we define infertility also as the use of fertility treatments. And actually very large proportion of our infertile participants used fertility treatment. And among those who used fertility treatment, actually 2/3 were successful. So overall, we have a much more detailed picture now on the fertility status of all our participants. And coming back to our initial question, am I able to conceive a child? I think here we can already give some more numbers. In our study among females, 74% were actually able to conceive a child, and among males, 56%. These are the ones that either used or did not use fertility treatments, but in the end were able to achieve a pregnancy. And as, of course, also Wennecken et al., we were interested if there is a possible association with genotypes. And again, here, very small numbers, but still, I think we could show some very interesting results. If you look here at this red box, where we summarized all the ones that are where we only had infertile individuals in our study. And for example, again, if we look at CCD, C40, actually all of the 5 females who participated were infertile. Then if we look at another gene, such as DNAH5, we see much more heterogeneous picture where like 8 females were fertile and 7 were infertile. Then DNAH11, in our study, all of the females who reported that the DNAH11 mutation were fertile. Now coming to our second question, if a female asks, am I at higher risk of having an ectopic pregnancy? We could include 197 pregnancies that were reported by 87 females. And here, luckily, most of these pregnancies resulted in live births. But we also had a report of 44 pregnancy losses and also 14 other outcomes, such as abortions or ongoing pregnancies, and these 15 ectopic pregnancies that we could that were reported in our study. And these 15 ectopic pregnancies were reported by 9 females. So some females reported more than 1 ectopic pregnancy. Now, of course, this number 15 doesn't tell us much, so we wanted to put it into context and calculated the ectopic pregnancies per 100 pregnancies. And there we are around at, in our study, we could show that around 8 ectopic pregnancies happen per 100 pregnancies. Now, if we compare that to the general population, here, again, I must say that the general population number is also very unclear. So it's reported to be around 1 to 2% of ectopic pregnancies in the general population. But I think you can still clearly see that we have many more ectopic pregnancies per 100 pregnancies in our study. And another number that I think is very interesting to share with you, that actually every 10th female who became pregnant had an ectopic pregnancy. Now, again, coming back to our initial questions, can we now answer them? I think we know much more now, but still, of course, we don't have a definite answer. So if someone asks us, will I be able to conceive a child? I think it's really an answer, maybe, but you might need fertility treatments. I think we could also show that, again, the risk for infertility is higher among males than females, but also that a big proportion of people actually could conceive a child also with the help of fertility treatments. And we could show that females are most probably at higher risk of having ectopic pregnancies. But again, we could really show again that there is really large differences in fertility among people with PCD, and most probably these differences could be explained also by different genotypes. Now, having talked a lot about infertility, fertility problems in people with PCD, we were, of course, also very much interested if this information is also shared with individuals with PCD, or what information they get about fertility in their PCD routine care. So we asked, is fertility discussed and managed during routine PCD care? And for this, the concept, I would like to introduce the concept of fertility care, which is defined as interventions that include fertility awareness, support, and fertility management. And here, fertility awareness also includes factors such as that something like age at attempt to get pregnant is very important. So that's as Sophie mentioned also, that there is this fertile window that if you're 45, it's much more difficult to get pregnant, and also other factors such as timing of sexual intercourse are in these fertility awareness factors. And then, of course, we wanted to see if there is any guideline available, but actually for PCD, there is no guideline on fertility care, so no guideline on information that should be shared or the timing of when this information should be shared. And actually, the recommendations are only based on expert opinions. So we don't have any data on what is actually going on in PCD care, what information is shared. So again, we sent out the questionnaire. It's actually the same questionnaire as the infertility questionnaire, just with additional questions that were also asked to parents and adolescents with PCD. And in this questionnaire, we asked different questions about fertility care. And here we could, of course, as I said, also include adolescents and parents, and we had a response rate of 53%. Now, what did we find out? When we asked them, are you satisfied with the fertility information we received from healthcare professionals? Actually, only around half of our participants were satisfied. If we mark them here in brown, we can actually also see very clearly that there is a large difference between females and males, that females are much less satisfied with the information about fertility they got. Then we also wanted to, we asked them which topics were covered in their discussion with the healthcare professional. And if we look on top, actually almost all of the participants were informed that people with PCD may have problems with fertility. But if we look closer at these two topics in the middle, that fertility treatments can help to conceive a child, this information was actually only shared with around half of our participants. And if we look at the bottom where we asked if other factors that influence chances of having a baby were mentioned, this was only mentioned to around 1/4. So these are these so-called fertility awareness factors. So I think we can conclude that not all relevant topics were covered. And then, of course, we were also interested if adults had the possibility to see a fertility specialist, because as you remember, there is no guideline on the topic, and we wanted to see what is actually done in PCD care. And actually only around half of adults visited fertility specialists. And only around 12% were actually referred by their PCD physician. The rest was referred either by another doctor involved in their care, or they had to organize the referral themselves or had to ask for a referral. And also these adults were not referred directly at transition to adult care or when they got the PCD diagnosis, but they had a median age at referral of 30 years. And that was actually, the referral was only done 10 years after the PCD diagnosis for adults, or 10 years after age 18 for people diagnosed during childhood. So then we thought, okay, but who is then actually seeing a fertility specialist? Who was able to visit one? And here we could actually show that adults with pregnancy attempts were more likely to see fertility specialists, and also participants who reported that fertility was important saw fertility specialists more often, and females less often. And here we can also see again that it's not a part of routine care, that people are not directly referred to fertility specialists because they have PCD, but only because they have problems conceiving. So coming back to our question, is fertility discussed and managed during routine PCD care? I think we can say that it's probably not enough included, it's not sufficiently discussed, and it also differs quite a lot between individuals. So we, of course, after this study, we cannot come up with a new guideline on the topic. For that, we don't have the correct data, but still we would like to make some recommendations on the topic, namely that care from fertility specialists should become standard in routine PCD care, and that it would also be important that PCD physicians really provide fertility information at diagnosis or transition to adult care. And these findings have been published this year in Pediatric Pulmonology. So with that, I would like to thank you, and also thank our participants and the PCD patient support groups. And I also mentioned here my email address, and also the very new URL we have for our website, pcd.ispm.ch, if you want to look up something. Thank you very much.
Thank you, Leonie. It was very interesting.
Thank you both. That was absolutely brilliant. Are you happy for us to start the Q&A session? Great. So I'll start with a question from the chat. We noticed a small number of scientific articles with research focused on infertility in women. There are many assumptions, but little study in the cilia of cells in the reproductive system. What is the greatest difficulty in investigating this genus?
Well, the idea was that in PCD, it's very difficult because you have no way to get a sample of the tube. And probably the disease relies within the tube, or maybe within the ovaries, but still it is very difficult to have a reliable evaluation of the follicle and therefore the oocyte number in women. So there are a lot of studies concerning women and fertility, but I focused mainly on the one that could be important for PCD. And of course, there are very few data.
Thank you. If I can follow up with a question of my own. So again, on the topic of the difficulty of getting the primary cells for research, is there an in vitro immortalized model that can be used for research? Or
not that I'm aware of right now, but of course, if it's a tubal infertility, then it should be easy to be cured, because IVF actually is a very good alternative and a very good, it can be efficient for people having tubal diseases. But we have conducted a study since the last publication looking at IVF in women with PCD, and it doesn't seem, the results seem to be quite good. So, but we don't have so far enough data so that I could share them today, but and we did not have any ectopic pregnancy. Of course, those women have IVF, but even when you have IVF, when you transfer the embryo actually could be within the tube, but it doesn't seem to be the case.
Thank you, Sophie. We have another question from the audience. He asks, I have always thought that in female PCD patients, motile cilia can be found in the oviduct, and the mitochondrial wave action of the oviductal cilia facilitates the transport of oocytes and embryos from the lumen to the uterus. The disruption of this is a major cause of infertility. Is that correct?
Well, this is a hypothesis, but there is no proof right now. To be sure about this, we would need samples of the tubes of the women, and it's not feasible right now. Ethically, one cannot remove a fragment of a tube, but it would be, of course, very interesting to have one tube to be looked at.
Lee says, great, thank you. A question from Molly. Thank you very much for the research and presentation. What do you think is the most exciting or important research to tackle next as it relates to fertility and PCD?
Maybe to both experts.
I think we probably have a different opinion on the most exciting or important. I would, of course, I would find it, or I think it's really important and interesting to have also clinical data on infertility, so that we would really need a big clinical cohort of PCD patients where we could really assess their fertility status as a whole, because we also try to ask them more questions about, okay, does your partner have any fertility problems? Do you have polycystic ovaries? Do you have endometriosis? But from a questionnaire, we can, of course, not really assess which factor is then really important for the fertility. So I think for us, or I think that would be really exciting to have a clinical cohort that is also like well genotyped, that we can also then look at, is there really an association between fertility status and genotype? Now, Sophie, what do you think?
Totally agree that we need data with a larger number of patients and longitudinal data, prospective data, because then we could have that would be ideal to have the genotype, to have how many treatment they had, and because one of the main marker now of fertility is the time to pregnancy. This is very, very important nowadays, saying when the woman stopped her contraception and how long did it take for her to be pregnant, the time to pregnancy. And this evaluation it would be very, very important for natural pregnancies, but also it would be very important to have data concerning whether the embryo actually could, the implantation was correct or not correct. And this, we have very few data about that. So we have started collecting data with those patients, but of course we need more to be conclusive and to be, of course, statistically significant. So we agree about what's more exciting about this.
I have another question. Are all PCD causative genes involved in reproductive cilia?
Well, some of them are definitely, but it's difficult to say all or not all, because if you have one case in, for instance, infertile, maybe you are going to have another case that is going to be fertile, and then the conclusions are going to shift from totally infertile to potentially fertile. So right now we need more data to have correlation between the phenotype and the genotype, I think.
Thank you, Sophie. We have another question from Lee. This is a more general question regarding fertility. Do you think the decline in fertility in general is at all related to the rise of microplastic levels within the body?
Oh, I think there are more issues than microplastic. For instance, well, there's also some tendency of some couples not wishing to have children. And this is quite new. And this is a major issue in Japan, for instance, where you saw the level of fertility is very, very low. Actually, people are making projections saying that in some centuries, maybe the Japanese population is not gonna be there anymore, because the rate of the population is decreasing a lot. So there's also it can be by the environment. It can be, of course, smoking. That's a major issue. It can be phthalate. This is why they have been removed in many things. It can be a lot of perfume, or a lot of nail polish can be the source of decreased oocyte. So there are many, many, many sources, and about endocrine disruptors. They are in so many things, and of course you're right in plastic, but it can be also in many other environment things. So right now there are many animal models looking at the impact of many substances on oocyte number and on fertility. But in human, it's very difficult to make the proof, because of course you cannot have an ovary to look at the number of follicles according to some exposition or non-exposition. And the other difficulty is that it's called the cocktail phenomenon, that everybody is exposed to many different endocrine disruptors. So therefore, it's very difficult to see which one is the most deleterious for the oocyte number.
Great, thank you, Sophie. Lee says thank you too. A question from me. Since you're talking about there is factors and impacting fertility, also which declines with age, are there any comparisons of longitudinal data of that decline that you described by age? For example, were there any studies conducted 20 years ago now compared to now, any further decline that people associate with environmental factors?
So the difficulty for answering this question is that a major point is a delay in the first child, meaning that if a woman has a child, let's say at 24, second child 26, maybe she was infertile at 34 or 35, but she was not testing her fertility at that point. So she's considered as fertile. But nowadays, as the mean age is for the first child is around 31 years old, and of course the second or potentially the third or the fourth children are after 35, then you may reveal an infertility that was not revealed before. So that's a major issue. An important point, however, is that the number of diminished ovarian reserve is increasing. There are some data from the USA where they have compiled all the data on in IVF centers, looking at what is the percentage of diminished ovarian reserve in women that are coming to a center for infertility. And they have shown that this increased. It was in 2000, it was about 10%, and now it's more than around 15%. So it's increasing. But is it increasing because women are coming earlier to have pregnancy treatment, fertility treatment, or is it because centers are more easily available? So there are a lot of parameters that are difficult to actually give the exact number of the potential impact of endocrine disruptors. But on diminished ovarian reserve, it's probably an issue.
Great, thank you very much, Sophie, for answering this question. Thank you both experts for this excellent talk. And since there are not any more questions, I think we close for today, right, Katie? Excellent. So thank you all very much.